And I've been on a lot of data safety monitoring boards and trial steering committees, and that's a huge privilege because you get to see things before they're out there, and then that gives you some insights into why we're asking the questions and where we are. And I've also, not as much nowadays, but certainly in the past taken care of inpatients and outpatients. But mostly I have an intrinsic need to have a systematic approach to a complex problem, and so partly why I've tried to organize this talk this way is hopefully to impart some of that systematic thinking to all of us as we go forward taking care of patients. The traditional disclosure slide is actually here. Remember that I'm a clinician, an administrator, and a researcher, but I do have grant funding, research support, and sit on these various steering committees and DSMBs. So what I'm not going to talk about today is innovations in dialysis therapies and approaches, because I have colleagues that are far more skilled at that and knowledgeable than I am, and nor am I going to talk about innovations and initiatives in transplantation. Both of those are really important for our patients, and I'm going to come back to the patient importance of all of this, but that's not what today is about. What I will talk about is global health and kidney diseases, because that's a pretty important thing in a lot of what I do now. What's old that we need to pay attention to, especially as internists, which we all are, and what's new that will change the way that we take care of patients and change paradigms. And so that's what I'm going to talk about. So just to give us all a context, I think we all walk around taking care of patients daily, but we need to remember that healthcare systems right now are economically unsustainable. In G20 countries, we're spending between 8 and 20% of the GDP on healthcare. And there's an infinite demand for care, and there's a finite amount of clinical and financial resources. We have aging populations and chronic diseases, of which kidney disease is one, but not the only, are increasingly high in cost. And we're not always as efficient as we probably need to be in terms of taking care of this. And so we haven't necessarily captured and used data to optimize our care, but we have a public that's increasingly expecting access to care. And I think it's important because what I'm going to try and show you is that there are ways to do things better, and we don't always have to do the most expensive thing just to take good care of patients. Kidney disease is a public health problem. It's increasingly recognized in multiple countries. And for those of you that follow the global burden of disease, kidney disease had the lovely privilege of going from number 25 in the world in 1990 to number 17 in 2015. And more recently in 2017 was actually holding its own there. That's for causes of years lost around the world. And it's important for us to realize that because it may be a good marker for how bad everything else is, and it's probably a good marker for healthcare systems and access to care. We calculated that 850 million people worldwide have some form of kidney disease. That's acute or chronic, and it's important, and I'll put them together for you in a minute. But that's the total burden in any one moment, and that's actually larger than the population of Europe and more than the number of people that have diabetes in the world. If you go back to the global burden of disease, the number of disability-adjusted life years is growing by a little bit over 1% per year, just attributable to kidney disease. So that's a huge problem for the world at large. And in 1951, if you go back to a very old rendition of the Cecil textbook of medicine, the whole therapy for uremia less than 100 years ago was actually wholly palliative, and there was very little that anyone can do. But now we actually talk about CKD as common, harmful, but treatable. And I want to show you where we've come in the last little while in terms of treatability. So around the world, we have acute kidney injury and chronic kidney disease, and they are inexorably linked, and I will show you how that happens. But importantly, from an access perspective, this is a lovely paper in The Lancet a couple of years ago that looks at who is not receiving renal replacement therapy. And it's estimated that between 2 and 7 million people per year who could benefit from renal replacement therapy don't get it. And it's because of expense, access, and healthcare system problems, really. And so for that reason, as part of an International Society of Nephrology initiative, we decided to develop a global kidney health atlas to be important in advocacy around the world so that people could actually show people where we were and where we weren't. And the main results of that 2017 are on this slide, and basically there are workforce shortages everywhere. Paradoxically, the places with the greatest amount of population have the least amount of nephrologists. right? So in Ghana, there are 3 nephrologists, but there are 47 million people in Ghana. And so there are poor CKD detection paradigms and therefore poor awareness. There's not a lot of funding. There's not a lot of recognition of kidney disease as a priority, very little planning, very few registries. So we'll get to that in a moment, and very little advocacy. And so all of that combined, as well as a deficiency in research capacity, means that this continues to be an ongoing problem worldwide. So from a global perspective, importantly, kidney disease is linked to a number of other non-communicable diseases. But as we look around the world, there's huge variation in the way we approach it, the resources and the policies. And I know you know this, but chronic, and the reason that in my title I called it chronic diseases, is that it's not one thing. It's a multitude, and there's a variety of ways that you can get acute kidney injury and a variety of ways you can get chronic kidney disease. And it's really important that we, working in a sophisticated, high-income healthcare system, understand how all of us can prevent and control chronic kidney disease and integrate with any other national or international non-communicable disease management strategies, because it's not about this is about people, not about disease specific. And the paradox for a long time has been that the amount of money that we spend, especially in high-income countries, for the treatment of kidney diseases is quite disproportional to the evidence base on which we have to inform clinical care. Now, that's changing. That's partly what I wanted to update everybody about, but I think it's interesting to reflect on this. So a couple of years ago in Vancouver, and for those of you that you probably don't recognize it, but that's UBC out by the library. So we got some clinicians, researchers, and translational scientists, as well as industry and others, to get together to address the gaps. And there's a Lancet paper that we wrote that actually describes a roadmap for how we close the gaps in care, research, and policy. And that's kind of important, because if we're going to make an impact locally or internationally, that we actually sing from the same song sheet. And this seems like motherhood and apple pie, but actually, so we want to improve the identification of chronic kidney disease and reduce risk factors. And so that's about surveillance, major risk factors, and reducing AKI. And we'll talk about that in a moment, because in this hospital, in this country, I'm not sure that we do that as well as we could. To improve the understanding and consequences of diseases by understanding genetic and environmental interactions, improve our diagnoses methods and what we understand about trajectories, and then develop and test new therapies. And that's where it's always exciting, but people don't always appreciate how exciting it can be. I'm going to go back a step and remind everybody that this definition and classification system is the cornerstone of a lot of what you learn. For the internal medicine people especially, but for all of us to remember that the definition of chronic kidney disease is an abnormality of kidney structure or function that's there for more than 3 months with implications from health. It has nothing to do with GFR. The GFR is how you classify it in terms of severity. And please remember not to confuse the two, because they aren't the same, and that you always need to understand the cause, the level of kidney function, of the glomerular function and albuminuria, so that you can actually understand a risk strategy. I'm not going to spend a lot of time on that because I know you all know that. In BC, 1 in 10 people have kidney disease. It doesn't mean they will all progress. At the moment, we have over 14,000 people registered not on dialysis, and over 3,000 on dialysis, and another 3,500 with kidney transplants. And we have a lot of people on home-based therapies. And we have a number of clinics around the province. It's a hub and spoke model, so we actually are pretty happy about the way that we distribute and ensure we have care for people. It's pretty expensive to have kidney disease, and our patients are much less likely to be employed no matter how old they are or young they are. This is a nice paper by Braden Mans from Calgary looking at the additional Canada Pension Plan and private insurance costs. Almost $1 billion per year is getting spent on the people in Canada. And so what we've spent a lot of time, or I've certainly spent a lot of time thinking about, is how we include our patients in clinical studies, because often they're the exact exclusion criteria for most studies, and how we actually get them to receive consistent care, because there's not a lot of study to inform them, and we don't always do things systematically. So I'll just run through for you the risk factors for chronic kidney disease progression. They're listed here on this slide, and Interestingly, the higher your GFR, the greater you are at risk for both progression as well as for AKI, and mostly because we're probably not paying attention to you the same way. If you have AKI, and I'll get to that, you're also at risk, and then the other list that you already know about. And the point of this talk is not to go over that, because I know that most of you know this. But what I want to do is go through some old and new knowledge around these 4 topics: acute kidney injury, anemia, polycystic kidney disease, and diabetes, and then frame it all in a patient engagement and patient-centeredness approach. And hopefully, for those of you that are undifferentiated at the current time, might get excited about all the cool things that are happening in nephrology. So this is a very nice slide that describes the burden of acute kidney injury and the implications. And that importantly, in terms of the episodes of acute kidney injury in high-income countries, including Canada, Australia, the UK, and the US, about 2 million episodes of AKI are occurring. And of those, a substantial proportion end up dying, going on to end-stage kidney disease, and almost half of them end up with profound impaired kidney function for a period of time before they then, and this is all within a 3-year period. Said another way is that within 3 years, if you had chronic kidney disease going into your AKI episode, 28% of the people will end up on dialysis within 3 years. If you didn't have kidney disease and had AKI, 7% of you will end up on dialysis in 3 years. And overall, that's 13%. So when you're looking at the AKIs that you're seeing in the hospital, you might sort of ponder that slightly differently. And we haven't changed the outcomes of AKI over time, and there's a lot of reasons. One is we probably don't use the right markers. There's a huge difference in definition, and there's a huge variation in care, and many of us are interested in trying to reduce that variation. And so, like I said at the beginning, I kind of like simple frameworks so that we can sort of always identify things the same way, so we can help to improve care and then help to inform research. Because if you don't get the diagnosis right, you'll never be able to get the prognosis and understanding and therapeutic options. So we have to recognize that very small changes in serum creatinine actually lead to poor outcomes. AKI doesn't mean you need dialysis. In the old days, that's what it meant. ARF was acute renal failure. Some of us are old enough to remember that's what we used to call it. And I want you to think of AKI like AMI, like acute myocardial infarction, these little blips of creatinine that mean that you've actually hurt something. And it's evidence of damage. And there's a lot of controversy about those small bumps, but I think I'll show you that it's because people say, well, we can't do anything about it. Why do you want to care? Well, because I think we need to start to look at them and care differently. And so we have to start with awareness and recognition. This is the original paper from 2005. It's a hospital-based study using all the lab data from hospitalized patients and all those small bumps. This is a creatinine of change of 26 micromolar in our units that is associated with an adjusted odds ratio of dying. And it was monotonically increased the greater your change in serum creatinine. And the Alberta group just looked at this in Alberta in the entire population and looked at these little bumps in creatinine and found this increase in hospital mortality, 1-year mortality, increasing length of stay, and a huge change in hospital cost for those little bumps in creatinine. So can you do something about it in this moment? Maybe not, but maybe just recognizing that this is something to pay attention to will help us to change the way we look at things. And we know that when you have AKI, you have a number of distant organ effects, and this talk is too short for me to go into all of them, but there is this crosstalk between organs. And when you damage one and create inflammation and various cytokine releases, there's a number of things that happen in the lung, the brain, the heart, the gut, the liver, as well as the bone marrow. And recognizing that complexity is why perhaps those little bumps in creatinine, which indicate no renal reserve, are probably the reason why our patients do so badly over time. And it's an area of very active study for many, many people around the world. And so stay tuned to this space because I think that there's a lot new that will come to this. What we do know, and this is something that I know you're sick of me saying, but fluid accumulation is not good for any organ, right? You cannot pour fluid into hearts, lungs, guts, and kidneys and think that they're going to work really well. And so this is the FACT study where they actually had the conservative fluid approach in the ICU versus liberal, and the mortality difference is striking. And this is a 5 liter increase. And it's because of the impact on all the organs that it's so problematic. And there are a number of studies describing the amount of fluid overload relative to outcome. And the longer you stay fluid overloaded, the more likely you are to die. And I'm not sure that when we're taking care of our patients, either on the ward, as outpatients, or in critical care, things that we're paying as much attention as we might want to this whole notion of volume overload. So if you are, the number of days that you stay overloaded actually increases the amount of time that you require dialysis and also mortality. And interestingly, we did a study here along with the CSICU people where we looked at 100 consecutive patients. And if you're 2 liters over your pre-op weight, with or without a change in creatinine, you actually stay way longer in hospital and are more likely to die. Now, truthfully, I'm not sure how much we all pay attention to that and do something to obviate that. But hopefully after this talk, we might have a different kind of interest in it. So the other caveat I wanted to leave you with from a practical perspective, remember that the more volume you have, and thank you, Peter, for the nice visual, the more volume you have a dilutional effect on the serum creatinine. And so in the context of volume loading, those small changes in creatinine might not be as small as you think, and no change may not be as good as you think. So serum creatinine of 200, 200, 200 with 2, 3, 5 liters positive is not good. It's actually bad, right? And again, I'm not sure how much we systematically pay attention to. There is a correction factor. I've listed it here. I would challenge us to try and use it systematically so that we actually are more cognizant of what is AKI. And for those of you that haven't heard of it, there's something called a furosemide stress test. That's a one-time dose of 1 to 1.5 milligrams per kilogram of IV Lasix. And it's super helpful because if the urine output increases to over 200 within 2 hours, it actually reliably predicts whether you'll get worse or whether you'll need dialysis. So if it's Thursday and you're not sure if you're going to need a dialysis catheter, why don't you try the FST so we can put in the line on Friday morning if they fail it, and then have a better way to plan things. I think these are the sorts of ways that if we think about systematically using things, it might be useful. So what I want you to do in terms of improving, or what we should all do together to improve patient outcomes, is recognize these small changes are related to adverse outcomes. Really pay attention to that fluid balance and overload, and calculate the serum creatinine, and maybe start to systematically use the furosemide stress test in clinical practice so that we get used to seeing how well it does or doesn't inform our practice. So switching gears to the chronic kidney disease populations, anemia is a really important comorbidity, and it's very multifactorial. It's due to iron and ESA resistance and some relative deficiency and inflammation. It's associated with a lot of terrible outcomes that the patients report. Cognitive impairment, as well as fatigue and exercise intolerance, which, as you can imagine, ends up causing them to not be fit, etc. And if you look at, quote, hard outcomes, as in things that you can measure without talking to a patient, there are a number of cardiovascular transfusions are a problem because it interferes with their transplantability, and they get lots of cardiovascular events, hospitalizations, and are much more likely to die. We've had for a long time ESA therapy and iron, and there's a number of issues in terms of what erythropoietin stimulating hormones we use, that sick populations don't do well no matter how high you try to make their hemoglobin, and there are some very some adverse effects in specific populations. And so there's been a huge ongoing debate about what's the right hemoglobin and what's the right set of therapies. And what's very exciting is there's a new kind of medication. So erythropoietin and iron are given intravenously or subcutaneously with respect to EPO, super physiological doses, some signal of harm in some high-risk individuals. There are people who are hyporesponders, and it's just expensive. These HIF stabilizers are oral medications. They're actually very new and very interesting, and may have some other really important impacts in terms of reducing the need for iron, because they stimulate iron absorption and reduce inflammatory cytokines. They impact multiple genes, which is kind of exciting because they might have some additional benefits, But when you they're gene activators, right? So hypoxia-induced factor is what HIF stands for, and basically you upregulate platelet-derived growth factor and vascular endothelial growth factor that may or may not be good for certain things. It's probably it looks like the HIFs actually improve glucose metabolism, which is interesting. In certain cancers, it actually may be not so good, because with breast cancers that are HIF positive, you'll find that you have worse outcomes. But there's some interesting anti-inflammatory in chronic GI inflammatory bowel syndrome populations. And it looks like immune-wise, it modulates the B and T cell populations, so you change the composition. And what the long-term impact of that is might be very beneficial. And there are some very, very promising results in phase 2 and 3. So that becomes some advantages and disadvantages of HIFs. So one of the other things we said we would do in the roadmap is actually improve diagnostic methods and understanding of projection trajectories so that we could develop novel therapeutic interventions. And so an example of that is polycystic kidney disease. And what's interesting about PKD is that it's the 4th leading cause of end-stage kidney disease. There's no racial predilection. All groups are equally effective. And we estimate that between 4,500 and 10,000 British Columbians have PKD. It's autosomal dominant, which means that you get a 50-50 chance if you have it of your kids having it, and we have families that are hugely affected, which is an issue. Now, what we've learned, so some of us were in medical school, we actually thought that it was a slow progressive decline over time, but what we now understand is that this is another hyperfiltration disease, and as the kidneys grow, the GFR is maintained for a very long period of time, and then it drops off. And we hadn't appreciated that for a long time, and people were getting referred very late and without a lot of things that one could do in terms of changing that trajectory. So we now understand that the physiology is much more complicated than we ever thought. There are a number of cellular mechanisms that we understand in cyst growth, and curiously, cyst growth in the kidneys leads to kidney failure, but cyst growth in the liver does not lead to liver failure. So it's a kind of a curious disease in that respect. I'm not going to go into that. But the new paradigm is that we now have sophistication to be able to look at people with autosomal dominant kidney disease and actually figure out if they're typical and genotype them if necessary, and atypical if not, and then have a systematic way to both approach, understand the size of the kidneys, what they're doing, and then what to do about it. And it sounds very basic, but no one had ever tested the idea of whether or not you could delay cyst growth by just controlling blood pressure better. And so this is over 500 patients with polycystic kidney disease with preserved kidney function who were age 37, mean age of 37, that were targeted to have low or standard blood pressure, and looking at the size and the volume of the kidney, because we know that that's related very much to whether or not you'll actually lose kidney function. And although the targeted didn't get the achieved, which is not a surprise for any of you in the audience who are used to hypertension studies, but there was a separation of about 10 millimeters of mercury in both. And the group that had the lower blood pressure actually had almost 15% slower rate of TKV increase. And that's just with very aggressive blood pressure control, irrespective of anything else. And so that's now become standard of care. When we actually surveyed the province of the nephrologists, we saw that the average blood pressure was more like 135 on 85. And most of us had become quite complacent because we actually hadn't quite appreciated the value of this kind of aggressive blood pressure control. So you might have heard that the role of vasopressin in ADPKD is actually quite exciting, and we know that we can block it with a drug called tolvaptan. So this new therapeutic thing has arisen, where we actually have now tested tolvaptan in earlier phase and later phase patients with polycystic kidney disease to see whether or not we could delay the progression of kidney disease through the use of this drug. So it blocks vasopressin, which is an important stimulator of cyst growth. It causes an aquaresis, which means that patients have to drink 3 liters a day of water. As a consequence, I lost my train of thought there for a second, sorry. Early and late kidney disease, to actually see if you could delay the trajectory, because each, millimeter that you don't grow your kidney actually adds GFR and therefore delays the time to need dialysis. Or more importantly, an ability to actually plan for living donation, because that's the other, or transplantation to avoid dialysis. So it's TEMPO 3, 4, and Reprise. And there are 2 large studies that actually show in the different populations very consistent results of a big change in progression of kidney disease. Now that's all well and good, except that even in this country, we don't have equitable access to disease-modifying drugs. It's approved in Canada, retails for $100,000 a patient year, retails. It's covered by private insurance in all provinces, but in this province, unless you have a private insurance, you won't be able to afford it, especially if you are lower income. So what we're trying to do is enable access to all based on data. So not every single person with PKD can benefit from this drug, and not every person should take it. So we've tried to make a case for who should get it based on best practices. And we have, a first-in-kind, really, BC ADPKD network, where there's a registry, a group of informed clinicians. We're modernizing and working with the radiologist. Sorry about that. So the notion of this network is that we can also try and improve the equitable access around this province to imaging, as well as treatments, and share the experience. And we've actually identified, and you can see from March 2015 to September of 2018, more people at earlier stages of PKD, which means that there's a group of people out there who may well benefit from therapy. And some of them won't, because when you're 80 and you have big kidneys, you don't need to take a drug that makes you need to drink 3 liters of fluid a day, right? So I think it's important that we actually inform in whom we give this medication. And we've working with the St. Paul's and the BC radiologists to standardize the reporting of kidney size and dimensions. So no matter where you go in the province, if you have serial workup of your PKD, you'll actually know that your kidney size did or didn't increase according to some standardization, and then offering some specialized clinics. And importantly, all of this has been done with patient partners. And I think that's kind of exciting, because they tell you what they want and what they don't want, and how often they want to be seen, which is very important, because they have a chronic lifelong disease. Their families have seen it all before, and there's a respectability that you need to have when you're implementing these things. So the last part I want to go back is to look at the novel therapeutic interventions for progression and complications of kidney disease, and how we're actually finally doing better and more clinical trials. And basically, it's to refocus on diabetes and kidney disease. And most of you, all of us, are impacted by the huge growth in diabetes worldwide. There, at the moment, are 382 million people, half of which aren't diagnosed. And the growth in that over time, especially in low middle income countries, is staggering. And that means that the implications for kidney disease are staggering. In this country, half of the people starting dialysis have diabetes, right? So that's important for us to know. Most of the non-traumatic amputations are diabetic, and a significant proportion of heart failure and heart attacks are actually in diabetics. So this is a group of people that we all take care of and we all need to pay attention to. And in the diabetics with kidney disease, all the same things actually apply. We need to control blood pressure, but importantly, prevent AKI and then recognize the impact that it has on their trajectory and the variability, and nephrotoxins that we give them. And then there's all the usual things that we know about. But I just want to stop with a couple of caveats. One is, not all patients with diabetes and kidney disease have diabetic nephropathy, so try in the language that you use to say diabetes and kidney disease, because it's not always the one and the same. They often have other things. Thank you. Yeah, that's what I thought. Thanks. So they can often obesity, or they can have a de novo GN, and you know how to look for that. But I think remember also that the eGFR, the E stands for estimate, and in diabetes it's an overestimate of true function. They often have no renal reserve. If they're hyperglycemic, they're hyperfiltering, which is the best they can do. So when you see a diabetic with a GFR of 40, it might not be that good, and it might not be able to withstand any stressors. If they're edematous, remember what I said about AKI? It's true in an edematous person as well, that volume overload will give you a dilution. The notion that Lasix hurts kidneys isn't true. If Lasix makes you volume contracted, yes, you can get pre-renal. But if Lasix removes the volume that was diluting your creatinine, it only unmasks the true creatinine. So when we're talking to patients and when we're talking to GPs, if we can please just remember that part, because a lot of people say, I can't take Lasix because it hurts my kidneys. It's not really true. And as I said, the reserve is limited. Acute kidney injury contributes to decline in these patients, often because it's under-recognized. And remember that the A1C in advanced kidney disease is not reliable. These patients have a reduced lifespan, and what we ask them to do is do their sugars, not their A1Cs. In fact, one could argue that we shouldn't be allowed to measure an A1C in a diabetic with a GFR of under 30 for sure, but we still do. So there's a lot of things that are implicated in the pathogenesis of the hyperfiltration in diabetes, and I'm not going to go through them with you, but there are lots of really wonderful exposés on this. But suffice it to say that it's a lot of things happening at a metabolic, cellular, and hemodynamic level that contribute to this hyperfiltration. And in the last 18 years, we've had very little new things come on the market or be available or be proven to be of value in the group of people with diabetes and kidney disease. And we have some new hypoglycemic agents, but what I'm going to talk about, and for the endocrinologists in the audience, I know that you know all about this, but it's the SGLT2 inhibitors, because they've certainly changed and rocked the world in terms of the things that they can do for people with diabetes and impaired kidney function. Parenthetically, metformin may also delay progression of kidney disease and is being tested in polycystic kidney disease to reduce progression. Just what's old is new. So these are the drugs, canagliflozin, dapagliflozin, and empagliflozin. I want to tell you a little bit about them because it's kind of cool. They're actually, the flozins are actually natural compounds that are from the bark of an apple tree that the French chemists actually discovered in 1835. And they used them to study diabetes in dogs because it induces a glycosuria and weight loss. And sort of it's a very interesting compound. So they got thirst, weight loss, and glycosuria. And then this guy, Robert Crane, on the back of a napkin actually drew what had to be the transporter that would be affected by this. And subsequently, in 2002, they actually found a mutation in the co-transporter that actually then led to the discovery of the drug, which is always fun to think about these things. So there's a tubular hypothesis of diabetic nephropathy about how the SGLT2 inhibitors reduce hyperfiltration via tubular glomerular feedback and actually reduce the amount of damage that's going on in the context of diabetic nephropathy. And they do a lot of things for renal protection. They improve glycemic control, which, as you know, is one of the cornerstones. They reduce insulin levels and improve sensitivity. But interestingly, they reduce your weight, your blood pressure, and your uric acid levels, all of which contribute to progression. And they directly impact by a number of other things, which is reducing the intraglomerular pressure and proteinuria, and prevent renal hypoxia. There's some really nice studies where they've changed the metabolism both in the kidneys and the heart of the way that energy is generated, so they reduce oxidative stress. So they're very fascinating medications, but that's all at a cellular level, and the clinical trials have been not disappointing yet. So the first one was EMPA-REG outcome. You will have seen that in New England Journal in 2016, and this really and for those of you like Canadiana, Bernie Zinman is a diabetologist in Toronto. And basically this was people who had good kidney function and diabetes, and it was 6,000 people at different doses. And the bottom line is that no matter what you looked at in terms of cardiovascular disease, empagliflozin actually improved the outcome in a group of type 2 diabetics. And then when you looked at kidney disease, We have not seen a slide like this since 1989, when Ed Lewis presented the first captopril study in kidney disease. It's a long, long time ago. So this is where the GFR goes down at the beginning and then plateaus as compared to placebo, where it goes down. And so this is quite fascinating because that's a big delta over the course of the period of time. And so if you look at incident or worsening nephropathy, the empagliflozin arm actually did much better, and that seemed to occur quite early on. The lines separate around 6 or 9 months, quite convincingly. And no matter what you looked at, whether it was new onset of worse proteinuria, doubling of creatinine, or the start of dialysis, all of the signals were actually in the right direction. And this is not people with kidney disease. This is early on. So remember what I said, how the higher your GFR, the more likely you are to have bad things happen. So it even stopped in these people. And if you look at it compared to ACEs, it's about the same delta. So it's a reduction in GFR that portends a good outcome that's comparable. Now, what's interesting is all the studies are done in addition to an ACE inhibitor. That's part of the way of going into the study. So canagliflozin is another flozin, and it was presented in the Canvas study in New England Journal in 2017. And basically, it's a sicker group of patients with type 2 diabetes, high cardiovascular risk, overweight, hypertensive, like lots of comorbidities, and lots with prior cardiovascular disease, and exactly the same thing. Less albuminuria, less going on to renal replacement therapy, less death, and less heart failure. And it did all the things that it was supposed to do: lower A1C, blood pressure, weight, and urine ACR. So it's all in the right direction. And with EMPA and Canvas, same outcomes are being seen. So we're getting more excited. This, in fact, is a real effect. And what's even more interesting is that you don't need to lower the glucose to actually get the effect. And so that has made it very intriguing to think about all the ways it's protecting the kidneys other than simply by lowering the glucose. And I've already alluded to some of this. And there are a number of ongoing studies to address it. And the cardiologists are excited because it looks like it's very good for heart failure, independent of glycemic control as well, because of its diuretic, blood pressure lowering, and weight loss effect, and probably the same thing with the cardiac metabolism and less interstitial fibrosis, etc. When you look at number needed to treat from the current data of just EMPA, it's as good as we've ever seen in a much shorter period of time. So 39 needed to treat with high CV risk, of whom they're already on an ACE. So you've reduced their mortality substantially in addition to best current therapy, which makes it quite exciting because we've never been able to do that before. And that's the value of well-done studies. So excitingly, Credence, which is actually GFRs as low as 30 with high urine ACR in diabetics, will report out in 2 weeks' time at the World Congress. DAPA-CKD is with diabetics and non-diabetics with lower GFRs, and empagliflozin, which we're going to start here, is between 20 and 60, irrespective of albuminuria, to see if in non-diabetic kidney disease this might actually also have effect. And there are some ongoing heart failure studies that have renal endpoints in them, and ongoing, obviously, real-world analyses. So we don't know if these drugs work as well without ACEs and ARBs. In the EMPA-REG and others, there were some people that had to come off their ACE and ARBs. Probably does, but it hasn't been tested. Who are the responders and non-responders? That's kind of the fun part of pharmacogenomics and understanding not every person needs drugs just because they're great in a study of 4,000 people. And so it goes, whether there are class and molecule effects. And importantly, what we've been trying to do in nephrology is take a systems biology approach and try and understand the biology, use some interesting technology and computational stuff, looking at tissue, biobanking, biomarkers, and responsiveness to medications, so that we can behave a little bit more like the cancer world and have the right drug for the right person and the right disease. And in this province, we have a GN network, which is part of a larger Canadian network, as well as transplant networks, and really trying to identify some new targets and therapeutic strategies for the rare, like the PKD and the GNs, and the more common, like CKD and hypertension. And the NIH is actually doing something called the Kidney Precision Medicine Project, which is where they're biopsying people with diabetes and kidney disease who usually wouldn't get biopsied. to see if they can find a molecular signature that helps us to understand who does and doesn't respond to various things and be able to reclassify kidney diseases in a much more profound way. And you'll remember that we used to think that there was one kind of breast cancer, and now we know that that's not true. Same with pancreatic, et cetera. So I think it's important for us to learn lessons from these other places. But just in the last little bit, I think it's really important to go back to the patients. And we are privileged to be the hub of a CanSolve CKD network, which is Canadians seeking solutions and innovations to overcome chronic kidney diseases. And these are the people that are part of the CanSolve CKD. These are real people. These are not photoshopped anybody. If I had time, I would name them all for you. Importantly, it's part of the CIHR Strategy for Patient-Oriented Research Chronic Disease Network Consortium. It's a pan-Canadian 5-year grant of over $40 million with matched funding. And we have a patient council and an Indigenous Peoples Engagement and Research Council, a number of core infrastructures and 18 different research projects, which map a lot to that roadmap that I showed you before. What's nice when you have this kind of a group is that you actually have patients living with kidney disease and their families, healthcare providers, researchers, and really importantly, administrators and policymakers, so we can actually translate what we find and put it into action sooner than later. For those of you who don't recognize him, this is Evan Adams. He's actually the First Nations Health Authority medical officer, and he's a physician, Indigenous, and also a researcher, and he's actually on our group, which is kind of neat. We have a patient council and what we call IPERC, and really important that we ground a lot of things in traditional values and partnerships with our Indigenous communities, and we have been doing a lot of work on learning pathways. But it's a different way of doing business when you engage the patients, because there are partners in study design, what they will and won't tolerate in terms of coming in for study visits and stuff, and that changes the way that you design a study and how you execute it. When we actually have the interpretation, they're actually helping us to say, how would I explain this to another patient? So that's the communication, but they also review all of the lay summaries, the manuscripts, as well as the protocols, which is really, it grounds you like nothing else to be able to hear. And they bring their perspectives, not just as patients with the condition, but also some of them are lawyers and businessmen and artists and teachers, and they bring that perspective as well. And so that's been very exciting for us. And so we've got these number of research projects, which I really won't go into, but we're going to try and improve living donor transplantation rates, look at symptoms and outcomes for those on dialysis, and look at novel cell therapies to delay progression. And the patients voted on which projects we were going to do using monopoly money, and they're the ones that chose which of the 26 that were presented, which 18 we would do, which was very sobering for the presenters and the proposers of the research projects. So if I just sort of go back and hopefully have some time and generate some interesting questions, I mean, what we did with that roadmap was say, if we could improve identification of CKD and reduce risk factors and understand causes and consequences and develop and test new therapies, we will get somewhere quite different in the world of kidney disease. And so that's what we've been trying to do. And what I think I've tried to do is hopefully give you some perspective on acute kidney injury as a risk factor, as something in and of itself, so that you can diagnose it early, avoid fluid overload, and together we might actually impact a whole bunch of people's lives quite differently if we all sort of think about it together. There are these new approaches to anemia, which are not just restricted to kidney disease, but that's the group in whom it will be tested first. And so that might actually lay over into other groups of patients. The example of what we were doing with polycystic kidney disease and diabetes and kidney disease is also important. There are other drugs coming that may also be important besides the flozins. And most importantly, the patient engagement aspect, which actually helps you to actually take best care of people, but also get them excited about answering questions within their world. So March is Kidney Month, and it is March 28th, so it was kind of timely that we did it. And I think that the World Kidney Day tagline was kidney health for everyone everywhere. And I think that as a collective, whether we're in internal medicine or a subspecialty, and no matter what part of the healthcare system we're in, I think if if we start talking about kidney health and not kidney disease, that actually changes it. And actually our Indigenous partners are the ones that told us that they were sick of hearing about how they have another disease, and can we not talk about something more positive? So kidney health for everyone everywhere is certainly a nice, a much more positive way to look at things. And so I'll stop there. Thank you to the patients and their families who waiting for us to work it all out. I think that they are incredibly brave. And to all of my colleagues at the division and the Pacific Nephrology Group, as well as all the students and residents and all the people that help us get the research done. And hopefully I've stimulated some thought or questions, and I'm going to stop there and have a little bit of time for questions. Thank you. Or you can go outside in the sunshine. Have to ask.
Thank you. That was an excellent talk and a great overview. We have a patient that does come in quite a bit who's young, who has like a cyclic vomiting, and she gets so pre-renal that she's had, over the years that I've worked here, multiple times come in with severe acute kidney injury, gets volume, and she makes a full renal recovery. Her urinalysis is always bland. So I don't think anyone has ever, including myself, talked to her about what this may mean to her kidney. So I just wondered what we should be doing, because she gets better and then she's like, okay, I'm going to go because I don't want to take up a bed. She's an employed person. So can I just ask you to comment about what we should be doing?
So I wish I knew what we should be doing. I think letting her know that this is an issue. I mean, it's obvious, it's likely not voluntary, or maybe it is. It's not voluntary. I mean, it's about warning her about risks of nonsteroidals, avoiding other drugs that might be a problem if she's of childbearing age, that might actually be problematic when she's pregnant. And just, it's about surveillance. At this point, we don't have treatment for people with recurrent AKI. But the more all of her physicians are aware, then, and I'm not sure how old she is, but when she's 60, she might be. So the other thing that would be interesting is what her blood pressure is when she's well, because if it's usually 90 and then all of a sudden it's 110 and then all of a sudden it's 120 consistently, then that's hypertension for her. And then addressing that might be important as she gets older. So I think at this point it's surveillance, but knowledge is power. And for her and for all of her physicians, it might be worthwhile to just pay bigger attention. And this is sort of part of the gray zone. And part of this kidney precision medicine project that the NIH is doing is so that we understand better. She may also be one of those people who is protected. So what is it about her that she gets all the way to normal with zero, like not even a urine ACR positive? She might have something that protects her, right? So, but great question. Thank you.
So what are your thoughts about when to check creatinine and how much to tolerate of a rise in creatinine or eGFR drop when starting an SGLT2?
So, it's like the same story with ACE. So the question for those who didn't hear it is, what's the ability to tolerate a drop in GFR with an SGLT2? It's the same as the ACE inhibitors, like 25 to 30%, and then follow up over time. It's probably a marker of a responder, right? The same ways as a responder in ACE or an ARB person, that if they don't drop, then they probably aren't going to benefit from the drug. I think there's been a lot of questions. We've all seen the N=1 acute kidney injury when they started an SGLT2, so now we're never using it. I reviewed every single study. There is no signal for AKI. These are random events that occur in people who are vulnerable to random events of AKI. And in all the placebo-controlled studies, there is no increase in AKI signal. Clear, like very acutely defined. So long-winded answer, but basically I'm quite tolerant of a drop of about 25 to 30%, and like everything, it's serially. I think we should measure creatinine in everybody. It's pretty easy, no matter what you think. And as I said, the diabetics with the highest creatinines are the ones most likely to potentially have a fall. Others?
In terms of renal protection, for SGLT2. We can use the SGLT2 to patient with DKD without cardiovascular event.
Yeah. So right now the EMPA was down to a GFR of 45. So that was without, the EMPA outcomes was without cardiovascular disease. CANVAS was with cardiovascular events. So I think the number of people who will benefit from it is increasing. At the moment, we can't do what's not on the label, but what's on the label is above 45. We'll see what Credence says. And right now, it's mostly approved for diabetics, not for non-diabetics. But the two studies that we're doing, DAPA and EMPA kidney, are both in non-diabetic as well. So we'll get an answer there. And just for interest, Credence was stopped early for efficacy. I've never seen a study stopped early for efficacy, right? You have to be pretty powerful and unethical to continue. And so in 2 weeks, you'll see the results of Credence, which will be very interesting. It's in diabetics without necessarily cardiovascular disease and impaired kidney function with high albuminuria. Great. I don't think remotely they can ask questions, right? And if they do, I don't know how to answer them. Okay, thank you.
I will be disconnected.
Thank you.